Welcome to Grand Rounds. Before introducing the speakers today, there are some housekeeping items. We're broadcasting live via live stream and YouTube. Please use the microphone to ask questions. The recording is always available for viewing. Consider subscribing to the YouTube channel to get notifications when videos are added. For our viewers, if you'd like to submit a question, text DeBakey to 37607. You may also submit the questions via the live stream feed. Our next conferences are the pre-intern for vascular surgery, scheduled on June 10th through the 12th, and cardiology for the non-cardiologist, scheduled for June 22nd. It gives me immense pleasure and honor to introduce two of our stellar graduating general cardiology fellows this morning who will be discussing my two favorite valves, the mitral valve and the tricuspid valve. Our first speaker is Dr. Smita Narayana Gowda, who is presently a third-year fellow and is our current chief cardiology fellow at Houston Methodist. She grew up in India and completed her medical school there before moving to the US to continue her medical training. During her medical school, she was actively engaged in medical education and advocacy initiatives through her involvement with the Medical Student Association of India. She then completed her internal medicine training at the University of South Dakota, where she also served as a chief resident during her third year. For the past 3 years, she's been with us here completing her cardiology training. During this time, she cultivated an interest in interventional and structural cardiology. She's moving to Mayo Clinic Rochester to start her interventional and structural cardiology fellowship this July. She's interested in medical education and curriculum development and aspires to continue her career as an academic cardiologist. Her research interests include structural heart disease and mechanical circulatory support. Dr. Gowda.
Good morning, everyone. Thank you, Dr. Faza, for your kind words. Today I'm going to talk about transcatheter mitral valve replacement. So to begin, learning objectives are who should be considered for TMVR, and TMVR in the context of bioprosthetic mitral valve dysfunction and failed mitral valve repair in rings and bands, and native mitral valve disease in the setting of MAC and no MAC, which is mitral annular calcification. And we're going to learn a little bit about dedicated mitral valve devices, and we're going to talk about considerations and pitfalls with TMVR. To make mitral valve disease is complex, just like the anatomy of the mitral valve. So to just make it easy for this presentation, we're going to divide the mitral valve disease into mitral regurgitation and mitral stenosis. Mitral regurgitation is two types, degenerative. There's primary degenerative or secondary functional mitral regurgitation. And in terms of mitral stenosis, there is rheumatic mitral stenosis and calcific mitral stenosis. And to go over a little bit about our current 2020 ACC AHA guidelines, what are the current guideline recommendations for interventions in these patients? For primary mitral regurgitation, the treatment of choice right now is mitral valve surgery. Repair is better than replacement. And if the patients are of high surgical risk, you can consider TEER. And for patients with secondary mitral regurgitation, we have data on mitral clips from the COAP trial, so you can consider that. And in terms of rheumatic mitral stenosis, for symptomatic patients, it is recommended to have percutaneous mitral valve balloon commissurotomy if it's anatomically feasible, if not mitral valve surgery. And in terms of calcific mitral stenosis, in terms of MAC patient, the guidelines recommend that you consider risk and benefit profile because these patients have high comorbidities and they have high procedural risk and prognosis is pretty poor. And I'm going to talk a little bit about mitral valve repair and replacement dysfunction because this is relevant to our topic of TMVR. So patients who have had bioprosthetic mitral valve dysfunction or repair, they can either have stenosis or regurgitation or both. And current guideline recommendation for symptomatic patients is surgery. So why do we need TMVR? There are patients who have high risk or prohibitive risk for surgery. So these are the patients we should be considering for TMVR. For this presentation, I'm going to talk about TMVR in the context of mitral valve repair or replacement with history of mitral valve repair or replacement, or in terms of native mitral valve disease. Patients who have had history of mitral valve repair or replacement can have failed bioprosthetic valve or failed mitral valve ring or band, and they can have high surgical risk. or patients can have native mitral valve disease and have calcific MR and severe mitral valve disease associated with that. Or they can have calcific, non-calcific mitral valve, mitral regurgitation. In these patients, in patients who have had failed biprosthetic valve or failed mitral ring or MAC, you can consider TAVR, sapien valve in mitral position, because these patients have an anchoring mechanism which can hold the valve in place. And in patients with native mitral valve disease, especially in patients with MR and calcific disease but not enough calcium to anchor the valve, those patients you can consider dedicated mitral valve disease. This is important because they don't have an anchoring mechanism and you need something to anchor these devices. And just want to talk about a little bit about how we have evolved in this transcatheter mitral valve space. The first thing that came in transcatheter mitral valve space is, of course, percutaneous balloon commissurotomy. And next there was mitral clip. And next there was sapien in valve. And then there was sapien in ring. And then there was sapien in MAC. And now we have moved on to dedicated valves. So first I'm going to talk about failed biprosthetic mitral valve and ring, mitral valve and mitral ring and band. So just to give a little bit of background, there are 40,000 patients who undergo mitral valve repair or replacement in this country. And 15% or 35% can have structural valve deterioration in 10 to 15 years. And patients who have had repair can have recurrent MR in 10 to 20 years. Depending on the place, it can vary from 6 to 27%. In our hospital, where Dr. Lowry is our main mitral valve surgeon, there is recurrence of 6% in 10 to 12 years. And patients who have to have redo mitral valve surgery have very high mortality risk of 11%. These are high risk patients. So there's an unmet need for patients who are high risk or prohibitive risk for surgery, or patients who are older or have very high comorbidities. So just to talk a little bit of data on valve in ring, and where this current evidence came from. We are going to talk about TMVR registry, which included patients who underwent valve in ring in high or prohibitive risk. And these patients were not eligible for surgery. This was done as a compassionate use. So those patients had mortality, the outcomes at 1 year was 12% of mortality in valve and 28% in valve and ring. And there was VIVID registry, which also looked at valve and ring. This was in patients. This is a registry that has patients who have undergone valve and ring mitral valve replacement. So the outcomes at 1 year, valve and valve was 14%, and valve and ring was 24%. And it's important to note that these two registries included patients who underwent a valve replacement transapically as well, because that's how TAVR and mitral TMVR evolved. First, most of the procedures were done transapically before moving on to transeptal. And then came the mitral trial by Dr. Guerrero from Mayo Clinic. So she prospectively looked at patients who underwent sapien in TMVR valves. Sapien valves in the mitral position for TMVR. They prospectively enrolled patients who were undergoing valve in ring, and valve in MAC. And they looked at their outcomes. I'm going to talk about how this is different than the previous registries. The 1 year outcome in this patient, a highly selected population, and all of the patients underwent transeptal access, and CT guidance was used to determine candidacy. So 1 year mortality was 3.3%. So making changes over time using transeptal access and CT guidance and making sure the patients are candidates for this TMVR, the mortality decreased to 3%. In terms of valve and ring, this was same in the mitral trial as a prospective registry, where the mortality was 23% at 1 year. These patients have higher all-cause mortality than valve in valve, which I'm going to talk about why. Because these valve in ring patients have more challenges than valve in valve. Because valve in valve, you have a circular valve, and you can put in they have an anchoring mechanism, and they can place a sapien valve, which is also circular in place. But valve in ring patients, they have different kinds of rings. There's incomplete ring, there's complete ring, there is rigid ring, there is semi-rigid ring, there's flexible rings. So they're not all the same. So there's a risk for residual MR or paravalvular leak, like you can see here, because there is space left behind. And there's also risk for valve migration and embolization, because rigid ring, semi-rigid ring, flexible ring, they're not all the same. And sometimes the incomplete bands might not have the anchoring mechanism anteriorly to hold the valve in place. And there is a risk for LVOT obstruction, which is more than valve in ring patients, because there's an anterior mitral leaflet that has not been resected, like the patients who have had mitral valve replacement. So this can interact with the LVOT and cause LVOT obstruction, which I'm going to talk about a little bit more later. And the valve in ring patients also have depressed LV function generally and have higher history of high rates of MI in the past. So these patients are high risk to begin with. So that's why the difference in valve in ring and valve in valve. And FDA has approved both SAPIEN valve in ring in 2017 and 2021. And then we're going to move on to valve in MAC. MAC patients, we all know MAC is a systemic disease. They have increased all-cause mortality and CV mortality. MAC, irrespective of severity, has increased overall operative mortality. And there's a specific surgical risk that is very specific to MAC, which is atrioventricular disruption. And older patients, and these patients are older and have multiple comorbidities. So they're high risk to begin with. Okay, so there's a lot of patients that are left behind because of these issues. They're older, they have multiple comorbidities, and there is a risk specific to surgery. So they started using SAPIEN or transcatheter aortic valve in mitral position in MAC patients as well as a compassionate use. And these are two registries that show their outcomes. TVT registry, which was done by Dr. Guerrero, the study was done by Dr. Guerrero, both of them. They showed that valve in MAC has a much higher mortality risk, which is like 21% compared to valve in ring and valve in valve. And they also, and the TMVR in MAC registry also showed that all-cause mortality was 53% in these patients, which was significantly high compared to valve in valve and valve in ring. But these studies showed us that LVOT obstruction is a significant, most important predictor of 1-year mortality. Why is this different than valve in MAC? Why is the mortality so high? Yes, we know that these patients have poor prognosis, increased higher comorbidities overall, but there's also anatomical considerations. These patients generally tend to have small LV cavity, and they tend to also have septal hypertrophy because of comorbidities, hypertension, diabetes, LVH. They also have a different way of interaction in terms of mitral valve annulus, the way the mitral valve annulus interacts with LVOT. They also have anterior mitral leaflets, which are still present. So they are at a much higher risk for LVOT obstruction than valve in ring patients. And they're also at risk for device migration and embolization because of the way MAC is. MAC is not always even. The severity of MAC can differ from patients to patients. Not all patients will have the circumferential MAC that we need for valve in MAC. So these things lead to mitral migration and embolization risk. And there's also a risk for paravalvular leak, again, because it's a circular valve. It's not easy to fit in a mitral annular calcification mitral valve because they have multiple humps and bumps that can interfere with the valve in place. And there's also risk of atrioventricular groove injury or rupture, which is pretty rare, but it is sure to cause mortality. And these patients are also older and have high comorbidity, so this should be taken into consideration. So the TVT registry, so how do we prevent these? How do we make the outcome better? So Dr. Guerrero's group also studied TVT registry in valve patients and saw, like in TAVR, transseptal axis is much better than transapical axis. So they used this to design a mitral. They took that into consideration in the mitral trial that I was talking to you about, which prospectively enrolled valve in ring, and valve in MAC patients who are at high surgical risk. All patients were transseptal axis. There was no transapical axis. And CT was used in all the patients to assess annular size, new LVOT, and risk for obstruction and migration. And preemptive all-cause septation was also used to decrease the risk of LVOT. So the data that came out was the 1-year mortality in valve in MAC patients was 33%, which was lower than 56% that we had seen. So we know that we can at least consider using SAPIEN valve in MAC in patients who have the right anatomical suitability and if you use transseptal axis. And now, currently, there is a Mitral 2 pivotal trial that's ongoing where they're evaluating in one arm valve in MAC patients who are getting all of the valves that are being used are SAPIEN valves, and all of them are going to have 100% transseptal axis. And the MAC score, which determines what is the risk of migration or embolization of the valve. If it's greater than 7, there is a low risk of valve migration or embolization. So all the patients need to have a MAC score of greater than 7. And the neo LVOT is also taken into consideration. If the neo LVOT, which I'm going to talk about later, is less than 200, then they can use alcohol septal ablation or a lampoon or radiofrequency ablation. They also have an arm where they're using patients with they're not enrolling patients who are not candidates for mitral valve inflammation, either because of anatomy or they do not want the procedure, and they're seeing how they differ. So we can have some outcome results in valve and MAC patients. And I'm going to talk about dedicated TMVR valves. Who are candidates for dedicated TMVR? So moderate to severe symptomatic mitral regurgitation patients who are at high risk for surgery, but they're not anatomically suitable for TEER. So those patients are who we should consider for dedicated TMVR. You can also consider them for patients who have had failed TEER and patients with MAC who don't have enough MAC for SAPIEN 3 valve, who are at risk for migration or LVOT obstruction or embolization. So dedicated TMVR valves, we have an array of devices that are in development, but I'm going to talk about just a few. There's a tendyne valve, which has an anchoring mechanism in the apex, and there's an interpret valve, which has an outer stent that interacts with the mitral annulus and keeps that in position with the help of cleats. And there's also a SAPIEN valve, which has a docking mechanism, which interacts with the mitral annulus before the valve is deployed. There's an alta valve, which is also a supraannular valve, which we can use. So first, tendyne valve. This is a valve where we can see that there's apical tethering. They tether the valve to the apex, so this doesn't require any other anchoring mechanism, just keeps the valve in place. So they showed that technical success was in 96% of patients, and the 30-day mortality was 6%, which was pretty good. So they went ahead with the pivotal trial, that is the SUMMIT trial, which has, this is the only trial that has a randomized arm which is looking at MR patients with TEER compared to TMVR tendyne valve, which the results are awaited. Who should we consider for tendyne valve? Patients who have symptomatic moderate to severe or severe MR who are not candidates for TEER or because of the anatomical suitability. Or who also if they have severe MAC, you can consider for the MAC arm. If they're not candidates for TEER, you can consider the non-TEER single cohort arm. And there's an intrepid TMVR early feasibility study, which showed the intrepid valve as the early feasibility study was successful in 14 out of 15 patients, and the stroke mortality risk at 30 days was 0%. So they went ahead with the pivotal trial, which is the Apollo trial. Apollo trial is also used. Who should you consider for Apollo trial? Moderate to severe or severe MR who are not candidates for surgery or TEER. So the patients who should be considering for interpret trial. There's also a MAC arm, which you can enroll patients in. First, I would consider SAPIEN valve. If they don't have a good anchoring mechanism, like the MAC is not severe enough, then these are the patients you should be considering for interpret valve. And then there is a SAPIEN valve or M3 valve, which has a docking mechanism which interacts with the mitral annulus before the valve is deployed. So they did an early feasibility study in 10 patients, and 9 of them were successful, and the 30-day mortality was 0%. So they went ahead with the ENCIRCLE pivotal trial, which is enrolling patients with moderate to severe MR who are not candidates for surgery or TEER. That is the main study, and there's also an arm for failed TEER registry, and there's also an arm for MAC registry as well, which the results are awaited for. Then we should also consider one important thing is that there's a very high risk for TMVR screen failure. This is from the CHOICE registry, which had 70% screen failure. It's just the most important cause for the screen failure is the risk for LVOT obstruction and the annulus size, which you should take it into consideration. And this brings me to the topic of LVOT obstruction, which is the Achilles heel of TMVR. We have known from previous studies is the number one predictor of mortality in patients who are undergoing TMVR, and are the main reasons for screen failure. So what can you do about the LVOT obstruction? We should always get a cardiac CT for assessment for new LVOT in patients who are undergoing TMVR. And the Wang study showed that new LVOT, which is measured in all the patients who are considered for TMVR, if the area is less than 190 millimeters square, those patients are at risk. They have 100% sensitivity and 97% specificity to predict that there is going to be increase in LVOT gradient in if the patient undergoes TMVR, which should be considered in all patients who are looking for, who are considering for TMVR. So there is a state-of-the-art article in JACC that kind of shows us when you should consider what, because there are a lot of ways that you can mitigate LVOT obstruction. There is all-cause septal ablation, there is radiofrequency ablation, there is sesame, there is anterior reflex reduction, there is Batman, where you balloon assisted, you translocate the anterior mitral leaflet, and there's also TMVR device also have some specific ways that they can avoid LVOT. So there are a lot of things that you can consider. So how should you go about it? So first, if the patients have risk of neo LVOT, if the frame neo LVOT, which if it's greater than 200 millimeters square, then you can proceed with TMVR without lamp-wound. But if the frame neo LVOT is less than 200 millimeters square, then you should assess for the skirt neo LVOT. If skirt LVOT is greater than 200 millimeters square and there's no interaction with the LV, then it's suitable for a lamp-wound. But if there is an interaction with the LV, like if there's an interaction with the LV, like how it's seen here, then you should consider all-cause septal ablation. But if the skirt neo LVOT is less than 200 millimeters square, and they have suitable anatomy for septal ablation, then you should consider all-cause septal ablation. If they're not a candidate for all-cause septal ablation, you should consider radiofrequency ablation and repeat CT to see if they're now a candidate for TMVR. These are just slides to show you how the valve interacts with the LV and the septum and how it can cause LVOT obstruction. So if the valve sits here and you don't have any more space left for the blood to flow into the LVOT. So this is what causes the LVOT obstruction and is the highest predictive mortality. So if they're candidates for all-cause septal ablation, you can do all-cause septal ablation, and when you repeat the CT, you can see that there is increased area over here. So this can make them candidates for TMVR. And the other procedure that you can consider that is more commonly used is a lamp-wound procedure. In lamp-wound, you split the anterior mitral leaflets, so it gives space for the valve here, the valve here, space for the blood to flow into the LVOT. So these are the two procedures that are most commonly used to mitigate the risk of LVOT obstruction. The take-home points: TMVR is used for high or prohibitive risk surgical patients. You can consider TMVR for failed mitral valve bioprosthesis and valve in ring. These are the two things that you can consider. And there is severe MAC, and if the patient has severe MAC and mitral valve disease, you can consider SAPIEN 3 TMVR if anatomy is feasible. And the new dedicated devices for patients with moderate to severe or severe MR, you can consider the new devices if they're not candidates for surgery or TEER. Cardiac CT should always be used to assess for anatomical feasibility. And LVOT obstruction is the Achilles heel for TMVR, and there is growing strategies to help with the LVOT obstruction. Thank you.
Thank you so much. This was a fantastic overview of the different TMVR devices and the strategies to mitigate some of these complications. We'll take a few questions from the audience.
Congratulations, Smita. This is really a great talk. Like, you gave a great overview about the obstruction and all the transcatheter mitral valve interventions. It's more of a comment than a question, but also the way to look into LVOT obstruction, it's not only like CT prediction models, but also looking at other things that can cause LVOT obstruction, such as like the leaflet length of the anterior mitral leaflet. One of the main issues is that the prediction models of putting a valve on CT does not really show how the anterior mitral leaflet behaves. So also the length is very important. So sometimes you might end up doing a lampoon even if the neo-LVOT is actually large. Mm-hmm. And sometimes if you don't do it, you get burned later on and you get LVOT obstruction from that.
Yeah, Smita, well done. It's very well put together, and thank you for kind of overview of all the aspects of mitral valve. As expected, I'm going to ask a hemodynamic question, not imaging-based. But when you look at the mitral valve and the regurgitation, there are some patients where your left atrial compliance protects the lungs and the wedge to go up. So to me, when I look at MR, you have a visual estimation of the MR, and then there is a hemodynamic impact of it. And we were talking about this in TR yesterday, that some people have severe TR, but the RA pressure is normal. My question is, are there subset in all these trials looking at clinical response based on wedge being high versus not?
The only thing that predicted worse outcomes after valve-in-valve and valve-in-ring or valve-in-MAC was patients who have had residual MR in terms of paravalvular leak or just residual MR. That was the predictor of worse outcomes in terms of MR. But there's no hemodynamic assessment as of now.
Is the data exist or we don't have
We don't have yet. It's too early. The trials are just ongoing. They're just pivotal trials as of now, so there's...
Thank you.
So, Smitha, congratulations. That was a whirlwind through a lot of clinical trials. You started off very nicely showing the different prognosis in patients with valve-in-MAC versus valve-in-ring versus valve-in-valve. And such a large gradient in risk makes me wonder if there's a selection of those individuals, if there's something about those individuals other than the actual valve anatomy that may be leading to their prognosis.
Yes.
So my question is, originally when we first started to learn about transcatheter valves with TAVR, the initial trial experience was comparing a transcatheter valve versus standard of care at the time. I may have missed it, but do we have trial data looking at standard of care therapy compared to some transcatheter mitral valve intervention in a randomized fashion?
So in terms of valve-in-valve, valve-in-ring, and valve-in-MAC, there is no randomized control trial because these are patients who are not going to get any other therapies, if not TMVR, because these are patients with high or prohibitive risk for surgery. And in terms of MR, the standard of care for MR right now is, in secondary MR, at least you can do TEER if they're symptomatic. And if they're symptomatic, so that's what's the guideline recommends, a two-way recommendation to do TEER. So right now there is a randomized control arm in Summit trial, which is enrolling patients for TEER or TMVR, irrespective of anatomical feasibility for TEER. Of course, they're only going to get TEER if they're anatomically feasible, but even if they're anatomically feasible for TEER, they're also randomized to TMVR to see what the outcomes are going to be. But these are patients who are high risk for surgery or prohibitive risk for surgery. They're not going to get any other therapies if not transcatheter.
Smitha, that was really beautiful. Within a short period of time, reviewing a complex topic. Question to you is obviously the prognosis of patients like who have a lot of calcification MAC. How much do you think, I know we don't have randomized trials, but how much do you think the bad prognosis is because of hemodynamic issues with the valve? And what I'm talking about is still severe stenosis because the MAC is extensive, significant regurgitation, or outflow obstruction. Because if these are not an issue and the prognosis is still bad, then at least you have within that cohort an idea of how bad the intrinsic disease and comorbidities are.
Yes, sir. Thank you, Dr. Rabbi. Of course, absolutely. MAC patients have worse prognosis overall. It's a systemic disease. So that's why they're doing the Mitral 2 trial, where they're enrolling patients for TMVR or no TMVR. But if no TMVR, if they're not anatomically feasible for TMVR, or the patient doesn't want to undergo TMVR because of the rest of the procedure, which is present. So that is so that we can look what's going to happen if they don't get anything versus if they're going to go TMVR, and that should tell us are we really helping these patients or not, and how much of it is because of MAC and systemic disease, and how much of it is because of the valve disease itself, and doing something about the valve will help or not.
Thank you so much. Moving on to our second speaker, Dr. Isadora Sande Mathias, who is currently a third-year cardiology fellow at our program. She was born and raised in Salvador, Brazil, where she completed her medical school. She then moved to the U.S. to pursue internal medicine residency at the Cleveland Clinic in Ohio, where she developed a passion for cardiology, cardiovascular imaging, and valvular heart disease. while working clinically, doing research with the cardiology imaging department over there. She then started her cardiology training here at Houston Methodist, and we're fortunate to have been able to recruit her to our advanced imaging fellowship, where she'll be dedicating a year to structural heart disease imaging and interventional echo. So she'll be with us guiding these very complex interventions. Her research interests include hemodynamics, valvular heart disease, and transcatheter procedural guidance. Dr. Mathias.
Thank you, Dr. Faza. It's a tough act to follow after my interventional colleague, Smita, but I will do my best to talk about this no longer forgotten valve. Let me just pull my slides here. All right. Okay. So the title of my talk is Transcatheter Tricuspid Interventions, Past, Present, and Future. And I have no disclosures. So a little outline of our talk today is we're going to do an anatomic review of the tricuspid valve, a rather complex structure. And we'll talk a little bit about tricuspid regurgitation, review the etiologies, mechanisms, and kind of the prevalence for each type. And then we're going to shift to the transcatheter tricuspid interventions, which is new and hot topic at this current time. And we'll go over some of the newest clinical trials and the ones that are planning to get started. And then we'll talk about, we'll take a quick peek on the future and see what the future holds for the tricuspid valve. All right, so the tricuspid valve is rather complex. Its anatomy has been described as multiple leaflets, not anymore 3 leaflets as it was classically thought. It can be from 2 to 5 leaflets. It has chordae, 3 papillary muscles, and an annulus that is D-shaped, highly dynamic, non-planar, and it can change up to 30% during the cardiac cycle. It lacks a rigid fibrous tissue, so it really changes significantly across the cycle. And its proximity to the AV node, the His bundle, and the RCA has significant implications for the choice of transcatheter devices and this new era of transcatheter interventions that we're seeing. On the bottom right, you can see a view of the tricuspid valve from the left ventricle. And there, on that patient, you can see that it has an extra small cusp. So this one is a quadricuspid, rather. Another view here in FAS of the tricuspid valve from the right atrium. And you can see here the proximity to the aortic root and the coronary cusps. Also, the annulus is very close, in very close relationship with the right coronary artery. As you can see, about 3 millimeters. And also you can see the septal leaflet, the anterior leaflet, and the posterior leaflet in there. All right, so based on this classification of this observation of 2 to 5 leaflets, Dr. Han and a big group of researchers took a look at several transesophageal echoes and defined classes of tricuspid valves. So the most prevalent is the classic tricuspid. We have 3 leaflets, but it can actually range from 2 leaflets to 5 leaflets. And the most prevalent is the classic. The second most prevalent is the type 3B here in the middle that encompasses 2 posterior leaflets. And here is one of the examples of one of our patients with 5 leaflets. And those are not clefts, so they're leaflets per se, and this anatomy has significant implications in the choice of tricuspid clip and other interventions. So a little bit about the causes and mechanisms of TR. So it can range from organic, or as we call primary, and iatrogenic from biopsies, leads, etc., and functional or secondary TR, which is from a dilation of the annulus. And here are some of the examples. So here in the middle, you can see a case of tricuspid prolapse, which has hypermobile leaflets. As you can see, the leaflets are highly mobile. Here you can see the opposite, where the leaflets are frozen, immobile in a patient with carcinoid disease. And down here, very dilated annulus, rather normal leaflet motion, however, they are tethered by the annulus being pulled. And here you can see a case of a patient that underwent endomyocardial biopsy and developed a tricuspid valve, a quarter rupture in a flail leaflet. So also excessive leaflet movement. And this is the distribution of the causes of tricuspid regurgitation, and the most common is left valvular heart disease, as it was previously thought, but also very common in secondary to pulmonary hypertension and LV dysfunction. Isolated TR per se encompasses 8% of the patient population. All right, so another very important point of describing tricuspid regurgitation is the novel grading scheme of this disease. So basically, it was found that TR can actually range from mild to not only severe, but massive and torrential. And this is very important for the purpose of guidelines and the purpose of the ongoing clinical trials. So, okay, the current landscape of tricuspid regurgitation. It has gotten a lot of attention over the past 10 to 20 years, and it's known that the prevalence is from 160,000 to 240,000 cases per year in the United States. Moderate to severe TR is 0.6% of the general population and 1/4 of all valvular heart disease, all left-sided valvular heart disease. It's often undiagnosed. The referrals come in late because these patients have very subtle symptoms. They will come to you with fatigue, with decreased exercise tolerance, with edema, ascites, and the murmur is rather soft. So sometimes they go undiagnosed for a very long time. The one-year mortality is significantly high. Some studies have shown, even with medical management, mortality of 36% and 42%. And even mild TR shows a 30% increase in excess mortality. So we need to treat TR. These are two other studies that I selected for this talk. On the left, you can see it's a population study of multiple patients with isolated TR and matched to match controls. And you can see a decrease in the survival, significant decrease in survival in the patients with isolated TR compared to patients with no TR. So this is a population study done in Rochester, Minnesota. And on the right, you can see a retrospective analysis, which is a little bit older study, but it analyzed more than 5,000 patients, and it was adjusted for age, ventricular function, size of the IVC, RVC size and function. And you can see that as worse as the TR, the survival becomes worse. So severe TR, with severe TR here and no TR here on the top. So a little bit more about the kind of current panorama and landscape of TR. This is a study that was very elegantly done. It was done in 2014. And basically took patients with isolated TR, so patients without left-sided valve disease, without any other major TR causes. And it stratified these patients to severity, to presence of AFib, and many other comorbidities. And across the board, patients with severe TR did worse. And it was a prospective study, so that's why it was very nicely done. They concluded that the severe isolated TR is associated with worse outcomes, even if you stratify for all these variables. And they also came with the conclusion that the estimated regurgitant orifice area, or EROA, is a powerful predictor of these outcomes, putting a very important stress on quantification. Even though we have all this evidence, the guidelines are rather complex, and the only class 1 indication currently from the ACC/AHA guidelines for tricuspid valve surgery is severe TR in a patient that's going to go for left-sided heart surgery. So we need to do better in that. We believe that this is because of high operative mortality, which can go up to 10%, 10 to 12%. It's a little better if the patients come in with milder symptoms and they're hemodynamically stable. And the standard assessment is rather imprecise. So we have, it's sometimes difficult to get good images in a transthoracic echo. Sometimes you don't get a good jet or a good PSA for evaluation. And some people are still unaware that you can get further imaging, multimodality imaging, and we'll talk a little bit about that as well. The European guidelines, on the other hand, in 2021, gave emphasis on the earlier surgery for tricuspid valve. They also recognized the new grading scheme that was proposed by Dr. Hahn and Dr. Zogby. And they believe that it has incremental prognostic value. And also, they put in a 2B recommendation for transcatheter tricuspid valve interventions in severe symptomatic patients with TR that are inoperable. So major change here. Okay, so shifting gears a little bit, moving forward to the transcatheter devices per se. I like to divide them and by the place they're located and the way they act, the way they function. I'm not going to go over the technicalities. I'm going to focus on the ones that are FDA approved and the current trials because everything tricuspid is really new. So first of all, the orthotopic transcatheter tricuspid replacement. So that's a valve replacement. You're going to put a valve at the actual tricuspid position. So that's why it's called orthotopic. The one that is FDA approved is the Evoque, and we're going to talk about the Evoque in a little bit. So the heterotopic, on the other hand, are the caval valves. So they're valves that are intended to treat tricuspid regurgitation, but they are not located in the tricuspid position. So those valves they're placed in the vena cava, and their main intent is to decrease the burden of the symptoms in very symptomatic patients that are otherwise not candidates for TTVR or TriClip, for instance. But we'll talk a little bit more about that and I'll show a case that we did here last year. Valve-in-valve TTVR, a little bit similar to what my colleague Smita was talking about for the mitral valve. You can put a sapien valve in a bioprosthetic surgical valve that has failed. Annuloplasty has also been done, although nothing has been FDA approved yet. And the ones that we know the most and we do the most are the leaflet approximation devices. So those are clips. We have the TriClip and the Pascal, which has been CE marked, approved in Europe, and currently enrolling in trial here in the US. And those are meant to approximate coaptation gaps and decrease TR. So a little bit on multimodality imaging, because it's very important on the evaluation of these patients. We have to reach our hand to multimodality imaging, and how each one of them is helpful is very specific to the kind of patient and kind of intervention. So for fluoroscopy and angiography, that's very important when you're trying to evaluate coronaries before the interventions. Also intraprocedurally, not only for device position, but for example, if you're putting an annular valve, like an orthotopic valve or a band, you would like to see how your RCA is doing during that procedure, because the RCA has a very close relationship with the annulus, like we talked before. CMR, very important in helping you grade TR when echo is not consistent, is not sufficient. Also, looking at the RV function and RV fibrosis in these patients is very important before going for the procedure and also after for monitoring of RV reverse remodeling. Cardiac CT is essential for procedural planning, looking at the shape of the annulus, looking at pacemaker leads that could interact with the leaflets, or it could provoke pitfalls in your study, in your procedure, and you can look at anchor points and hinge points of the tricuspid valve. So very important for procedural planning. ICE also came up as a very good alternative for patients that cannot be esophagically intubated for the TE, patients that cannot undergo general anesthesia, and it can be very helpful in patients with artifacts from leads and from left-sided valves, like mechanical mitral valves, for example. So shifting a little bit to the main trials, I'm going to focus on the two most recent big ones that got released in the past couple of years. So the Triluminate trial was an international randomized trial published in the New England Journal of Medicine, and it evaluated the Abbott TriClip, which is a transcatheter edge-to-edge repair of the tricuspid valve. So the results of the Triluminate were robust in terms of the severity of TR at 30 days. So these patients had, so 87% of the patients had moderate or less TR after 30 days. And compared to 4.8% in the control group. So it was a randomized controlled trial. An interesting fact is that 55% of the patients were women, which is not very common in big clinical trials. So also the big end product of the Triluminate trial was the change in the KCCQ quality of life score. And this pretty much had a very robust relationship with the decrease of TR in these patients. So the patients that had reduction in tricuspid regurgitation also had improvement in quality of life. And the quality of life questionnaire and the tricuspid regurgitation assessment was done in a blinded way. The study itself could not be blinded for obvious reasons, but this result was evaluated in a blinded way. So this is just one of our cases illustrating how we do the TriClips. I just wanted to illustrate here is the TE guidance. On the top left, you can see a patient with a severe intertorrential TR. And on the second picture, the catheter is being placed. And the third picture, you place the first clip. So I put two of the fluoroscopy images here. This is the TE probe, and this is the Agilis catheter, but the catheter with the TriClip. And here I just made an illustration of two clips in situ. This one is about to be closed and deployed, and this one has been deployed. So this patient got a final result of mild to moderate TR, which in tricuspid edge-to-edge repair is considered a very good result. All right, so shifting gears to the TRISCEND study. So the TRISCEND study was published in the European Society of Cardiology journal, and it was the evaluation, it was a study of the EVOQUE TTVR valve. So it's a transcatheter valve itself. It was not a randomized clinical trial. We did not have a control group, but it showed the safety and efficacy of the EVOQUE valve. So some of the results showed a robust decrease in TR, and this was sustained over a year, as you can see on the graphic on the right. It's a very colorful graphic, but it does show that these patients really, the patients with moderate to severe, all went green. So the excellent TR reduction. Also, there are significant improvements in NYH class symptoms. The quality of life KCCQ questionnaire and the 6-minute walking distance, which was not a result that was seen in the Triluminate. They didn't see any changes in the 6-minute walk distance. Their 1-year mortality was 9.1%, which is comparable to tricuspid valve surgery 1-year mortality. So as a few of the pitfalls, of course, these trials were major and they received some criticism. For the Triluminate trial, the outcomes were mostly driven by the quality of life. So all the other mortality, cardiac events, et cetera, those did not show significant difference. The incidence of all the other things did not difference. There's no difference in 6-minute walk test, and there's a criticism of the possibility of Hawthorne effect. Like these patients, they know they got the valve and then they report the quality of life to be better. So they try to blind it in a way where the person applying the questions and the questionnaire and the assessment of symptoms did not know the results of the TR reduction, but still, this is a big possibility, and more trials need to be done to try to blind for that. For the TRISCEND trial, the main issue was the major adverse events. So at 30 days, these patients had 18.6% major adverse events, and at 1 year, 30%. It was mostly driven by bleeding, and the authors believed that those adverse events are inherent to those populations. So these populations are already sick to begin with, and they would probably get those adverse events with or without the valve. The need for pacemaker placement in the first 9 days was 13.3%. Still, those were two very powerful trials, and they led to the 2 FDA approvals this year. So the EVOQUE got FDA approved in February, and the Abbott TriClip got FDA approved in 2024. And this is our team here in the Texas Medical Center making history with Dr. Goel, Dr. Faza, Dr. Little, placing the first commercial TriClip in Houston, Texas. I wanted to talk a little bit about the caval valves because I think that the concept is very interesting, and it's currently approved for compassionate use in patients that are very symptomatic. The coaptation gap is too wide for TriClip, like you cannot approximate those leaflets, and the annulus is too large for TTVR. So we did our first compassionate case last year, and these are some of the pictures. And the interesting concept of the caval valves is that they can bypass those anatomical challenges that some patients have. And it can be a big hope for patients that are extremely symptomatic, not surgical candidates, and not candidates for the other procedures. And this is how the valve looks on the patient, the superior vena cava and the inferior vena cava, preventing the consequences of the backflow caused by TR. So some trials to watch for are the CLASP II trial, which is enrolling to evaluate the Pascal device, which is the kind of cousin of the TriClip. The TRISCEND II trial is going to be a pivotal trial, so randomized trial of the EVOQUE valve. And the TRICAV trial, which is awaiting initiation, it's a trial that's going to include the patients that are usually excluded from trials. So, and it's for the caval valves. With that, I would like to conclude that the tricuspid valve is definitely no longer the forgotten valve. I like to call it the valve of the year. 2 FDA-approved devices in 2024, increasing clinical awareness from everybody. And you know, the future is here. I developed this little diagram just to kind of wrap up and show everybody what we have to be looking at for the tricuspid valve and when to think about tricuspid interventions. So we need to improve our quantitation. We need to improve our diagnosis and like our threshold for multimodality imaging. And treatment-wise, timing for transcatheter interventions and the election of devices needs to be continuously studied. And for the outcomes, improve our post-procedural assessment, like how much TR reduction is a good amount of TR reduction, because we're not going to always have mild in the end. And of course, come up with new trials and new studies of the multiple devices that we have. And with that, I'd like to thank Houston Methodist for an unforgettable 3 years, and I'm happy to take any questions.
Thank you so much, Dr. Mathias, for a fantastic overview of the valve of the year and demonstrating how it's finally time to treat TR in those patients at a high surgical risk. Any questions?
This one was great, really good, and I really commend your passion for tricuspid valve and the enthusiasm as well. But history and the surgical data is really important to know because, as far as we have a really solid data historically because of mitral stenosis, which is the landmarks of the surgical history and tricuspid regurgitation and all those things. And we have not shown any significant survival difference through the years for this repair of the tricuspid valve. There is a morphological or structural deformity of the valve. So the idea was coming, it's a surgery, so maybe we can, without surgery, with the transcatheter approach, show something. But the thing is that we always forget that it is, again, I'm just isolating the isolated structural and morphological problem of the valve. The tricuspid valve is when they are really in the severe regurgitation point, is the tip of the iceberg. And
Yes.
there is it's not only valve problem, it is a RV problem where when the RV is dilated, is to bring back it is so hard. It's not like LV, it doesn't recover very much. And also additional to that because of the systemic backward effect of the hemodynamic, the liver is involved, the GI system, and systemic effects. So I really, like technology is amazing, and this field needs to be explored, especially because we are avoiding the insult of the surgery for these people. And especially that if we can have some solution, it will help a lot to the transplant patient, for example. And sometimes they have a structural abnormality, but when with the surgery trying to correct those, it's real outcome is not that different. So I just wanted to take the history is always important, and it comes back to, and I think when we going forward with the technology, we need to think about that too. That was my comment.
Absolutely. Thank you so much. I'm very appreciative of your presence and your surgical inputs on the top.
Isa, that was a very nice overview. Maybe a reflection and a recommendation. One is you showed, and everybody knows, that the vast majority of TR is secondary. So maybe a plea actually for all the physicians and cardiologists is prevention. Prevention meaning if you have left-sided heart failure, pulmonary hypertension, please, I mean, nowadays there are quite a few medicines that could be used to decrease the effect on the right ventricle and therefore tricuspid regurgitation. So you have to be aggressive. Number two, which is not surprising that the outcomes are not very different from the way we enroll patients, is new data showing that if you have significant RV dysfunction, and you could measure it whichever way, ejection fraction, fractional area change, free wall, longitudinal strain. If RV is significantly dysfunctional, tricuspid regurgitation is lesser of an effect in outcome, meaning the RV is the driver as opposed to tricuspid regurgitation, meaning you could fix tricuspid regurg, you still end up with everything else of diastolic dysfunction, volume overload, poor outcome, poor output, everything else. So therefore, I mean, you have to keep that in mind, and I know that many of the trials will start involving patients with some lesser degrees of RV dysfunction, to influence outcome.
And that's a significant role for multimodality in this case, because if we come up with more MRI markers, for example, we can maybe see when do we catch these patients earlier and when would they do better.
Thank you, Isa, for the great talk. I think Dr. Akai and Dr. Zogby bring up great points, and they're extremely valid in a way that we have to figure out as a community which patients to treat and with which device, and which patients to not treat because they're either too far gone, or they're either too early, or we're not treating the exact cause of their disease. So the Europeans have had longer term experience because they've had CE mark on some of the devices longer than us. Have you encountered in your review any algorithms or any specific populations that can benefit from certain devices, or some populations that do not benefit at all from any intervention transcatheter-wise?
Yeah, so thank you, Joe, that's an excellent question. So from what I've seen, mostly the anatomy of each patient dictates the device. So patients that have a too big of an annulus cannot get, for example, the orthotopic valves. Patients that have too big of a coaptation gap cannot get clips, for example. So that's very important. And also patients that are, as Dr. Zogby was mentioning, too far gone from a matter of RV dysfunction. So I think that's the main issue with planning tricuspid interventions, is to try to figure out when to do it, the timing, and if we should do it, when it's too late or when it's the right time. I think that's kind of the food for thought for the next 10 years.
It's a great talk. Between the tricuspid and mitral, you guys need to arm wrestle and figure out which is the valve of the ear. But I think that the tricuspid interventions, really just a comment and then kind of a question for both of you based on the comments earlier. The tricuspid valve has really, this intervention as an objective thing for people to perceive, has opened up the arena of venous system and venous congestion, which has been understudied. Similarly, there are other devices like precardia that is in trial. It's opened up the venous capacitance and how much physicians and patients don't respond to liver congestion, because you're short of breath with the mitral valve because it's lung congestion. You're not short of breath with liver congestion. So it lingers ears to ears. So I'm hoping this field will then evolve into understanding a lot of these early prognosticators, how to measure the venous system, how to measure the capacitance. So as Dr. Zogby said, act earlier.
Yes.
My question to you all as the field is, if the story of MITRA-FR and COAPT very clearly tells you that if you don't pick the right population, you're not going to get an impact. And not to self-proclaim our field, but the difference between MITRA-FR and COAPT was that COAPT had a very strict advanced heart failure cardiology screening. But when you turn that into clinical practice, Medicare is not mandated, no one's mandated heart failure physician to be a part of the valve team. We have the luxury of it here, and I think Dr. Faza and Dr. Goel have become heart failurized. That when you expand it to the rest of the world, the question becomes, how do you control not just putting in valves? Because we've had some cases, luckily, you guys are a screen, but we've had cases with new diagnosis of PH. PH was ignored, but you get referred for a tricuspid. It's good they're getting referred, but it's opening up this area of making sure that we understand that hemodynamics and management and how to incorporate multiple things.
Brilliant comment, as always, Dr. Bimaraj. I think that we have to stress the importance of a comprehensive valve team, like we have here, like we have, for example, the adult congenital team here, and that has to include a heart failure hemodynamicist for understanding how these patients are going to do, and also making sure that all these patients on trials are on GDMT, and having these valves just as an add-on to the GDMT that is very important, and it's very widely proven to work for all the patients.
And a comment on that, Dr. Bimraj and Isa. The way that we do it here is every patient with significant TR is referred to the heart failure clinic. They're optimized. They undergo a right heart cath at the time that they have the TE. And there are many patients, both with secondary mitral regurgitation and secondary tricuspid regurgitation, who have significantly improved. And we've seen TR severities go from severe to mild. So it's important to remember that you're treating the patient. You're not treating a lesion. And I think this should be emphasized in the next iteration of guidelines, similar to how the guidelines are for secondary mitral regurgitation. Is the first step is optimization, GDMT. This should be the first step, and then if that doesn't work, then you start considering other transcatheter options. So it's important to treat the patient as a whole, not focus on the lesion, and realize the important role of GDMT. And I think the more data and the more evidence we have for treatment of right-sided disease will also be helpful in elimination of some of these patients, TR lesions that we see. Dr. Martin?
So just a quick comment. For once, the congenital heart population actually may be helpful in this setting, because obviously in the tetralogy of Fallot patients, completely a different valve, but decades of data now about RV performance and RV dilatation and timing for repairing the pulmonary valve. Again, extrapolating to a different valve. But like I said, for once, the congenital heart field may be able to help the acquired heart field with some of the data there. But the second thing I think it highlights is that we actually don't have GDMT for RV failure. And I think that is one of the things that I think is challenging, because in the mitral valve field of helping to recuperate the LV, we have medications that we know that can help and unload. And I completely agree, optimizing the volume status and other things. But I think the RV is still the forgotten ventricle when it comes to medical
Absolutely.
therapy. And, just as you know, my passion of RV, it's different. It's embryologically different. It's structurally different. And so I think these trials, will highlight that and hopefully help us look at other medications to intervene there as well.
Absolutely, Dr. Martin. Brilliant. Thank you.
All right, thank you, everyone. Thank you to our speakers, and we'll see you next week.